So welcome everyone to the Autism Prevalence in the District of Columbia, How Many Autistic Children Live in DC webinar. This event is hosted by the DC Autism Collaborative, a multidisciplinary public-private coalition of professionals, community, and parent leaders who have come together to strategically address barriers to autism care and advocate for solutions that will increase early and equitable access to high-quality autism diagnosis, treatment, and coordinated care. Just want to note that primarily our group right now, until capacity, grows, we are primarily focused on early childhood. I know there are a lot of challenges in the city around autism, and there are so many children who and youth who need to be supported, but just want to call that out right here at onset. My name is Yetta Myrick. I'm the president and founder of DC Autism Parents, and I'm also the Centers for Disease Control and Prevention's Learn to Signs Act Early Ambassador to the District of Columbia, as well as a core team member to the DC Autism Collaborative. But I think the most important role that I'm coming to you from today is as the mother of a now 20-year-old, soon to be 21 in September at the time that we're recording, of a son who is diagnosed with autism, ADHD, and an intellectual disability. I'm now going to turn it over to my amazing colleague, Leandra Godoy, who leads the DC Autism Collaborative, and she's going to introduce herself and talk to you briefly about the history of our collaborative.
Great, thanks, Yetta. So I'm Leandra Godoy. I'm a psychologist at Children's National, and I also lead the DCAC data subgroup. Yetta mentioned that the DCAC is hosting this event, so we want to briefly share some information. As Yetta says, a public-private coalition. We have over 90 stakeholders that includes health, education, advocacy, community groups, in addition to our family advisory group, and we convene to improve autism care in the district. So we have subgroups to address different areas and have developed different resources for families and for providers that are freely available at the website. And so as mentioned, one of our subgroups is focused on data, which is the topic for today's discussion. Okay, so we want to go further about kind of why gathering data about the number of autistic children in DC is important. And we know that this information is used to determine policy, resource allocation, and other decisions, such as which programs and services may be most needed. And if children are not accurately counted, they may not get the fair share of money to fund the needed services. We also know that data shows patterns over time and needs or inequities based on factors such as race or sex and ward. And so this information can then be used to address any concerning trends. And knowing more about the prevalence of autism in DC and information gaps can inform advocacy efforts to ensure that autistic children in DC get the recognition and the resources that they need. So we're grateful for the speakers we have today who will help us understand the national and DC data that we have.
So first up, we're going to hear from Dr. Matthew Maynor. He is an epidemiologist and the chief of the Child Development and Disability Branch at the Centers for Disease Control and Prevention, yes, that CDC, down in Atlanta. Dr. Maynor previously led the CDC's Autism and Developmental Disability Monitoring Network, also known as ADAM, which tracks the prevalence of autism among children, progress in early identification, and needs of adolescents in multiple U.S. communities. Dr. Maynor received the Presidential Early Career Award in Science and Engineering for advancing developmental disabilities research and surveillance. Matt will provide an overview of the ADAM network, explain why we need autism data, how data collection varies by state, and the difference between educational classification and medical diagnosis in collecting autism data. Dr. Maynor, take it away.
Well, thank you, Yetta. I just want to say how thrilled I am to be invited to this because it combines two of my favorite things, which are getting data in places that don't have data, and then being a part of things that Yetta is starting because she makes things happen. And I think this is a really, really exciting initiative to help support. So as Yetta said, that so the presentation is going to tell you basically three things: what the data look like, kind of how it works and what it can show you, In looking at that, I want to tell you, I hope you can see why there's a need for local data, why you can't just rely on national averages to inform local action. And then to give a couple quick examples in what communities do with the data. And I think that you'll hear, I'm grateful my colleague, Dr. Hall-Landy is on, and she leads our ADAM site in Minnesota. So she has been part of all of this work. She is also one of our ambassadors to the state of Minnesota for the Learn the Signs Act Early program. I'm not like burning her intro for Yetta, I hope, but she can speak really to what communities do with these data. I think I can tell you a better idea of like kind of on a high level what they do with it and what the different communities other than Minnesota have done. So the ADAM network, the Autism and Developmental Disabilities Monitoring Network, is a kind of the most cited source of autism prevalence data in the United States. This graph shows the overall prevalence for autism in 8-year-old children over the years. ADAM reports data in even numbered years from geographically defined areas, which you can show on I think go to the next slide for that. This was the most recent data that were reported based on the surveillance year 2020. So the counties that were included were in green, and it tracks children identified with autism that were either 4 or 8 years old in the green areas in these states. So it's not really nationally representative, but it's very diverse. There's a lot of very completely different situations in different communities. And if you go to the next slide, this is our case definition. So when you're tracking autism at a population level, it's really important that you do things consistently and then also simply. It gets really hard to make sure you do things the same way everywhere. And so you have to have a really clearly defined, it's called a case definition in public health surveillance. So it's like, if we're going to count somebody, we need like a really black and white way to know whether to count them. And the way that ADAM counts children is if they have any one of 3 things in their records across the sources in the community. So that could be if in an evaluation, a professional says, I'm giving this child an autism spectrum diagnosis, we would count them. If they have a special education classification of autism, because they're served in schools and the school deems them, best served by that label, we would count them. And even though that's different than a diagnosis, it's a way to get services. The child is being described as having autism, and our analyses have shown like a pretty high overlap between the 2 classifications, at least on the zoomed out level that we're counting them on. And then the third is an ICD. So people sometimes call them billing codes. These are, can be attached to, administrative data that come in through like, Medicaid or other services. If a child has any one of these, we would say that they're a case and we would count them. So if you go to the next slide, this shows the overlap between those 3. And what I want to emphasize here, and by the way, all these data are publicly available. So if something catches your eye, and I'm going quickly, it is online. You can reach out to me or our ADAM team, and we can point you to the full source so you can really dig in. But this shows that there's, there is a lot of overlap, but also each of these are contributing uniquely to think about all the different ways that children are being identified and served in the community. They're coming through different pathways. And so we try to capture as much of that as possible to get like the full picture about what is happening in these communities. And on the next slide, this shows another way of sort of showing that variation across the sites. We created mutually exclusive categories here. The bars are autism prevalence. The green is everyone that has like a written clinical diagnosis. We felt like that would be probably the thing that would be the clearest indicator. Blue are children without that diagnosis, but have a special education eligibility. And then purple is that they don't have either a diagnosis written or a special education classification, but they do have one of those ICD billing codes. And you can see there's some variation, not only in the prevalence of autism across the states, but also the ways in which children are being identified in their community. There's some really interesting patterns and little factoids that you could go into, like why does New Jersey have so few children that only have a special education? Like there's a very little blue there in New Jersey. That's because in New Jersey, it's almost required to have a medical diagnosis to get a special education. Like the policies and requirements are different in different states. So you could get a different sense of what's happening depending on, you know, which community you're looking in. So on the next slide is just that there are also differences by race and ethnicity in terms of the prevalence. What's interesting is that over time, these differences have shifted. Previously, the highest prevalence was among white children and among children in higher versus lower income neighborhoods. And over time, that gap has closed, and now it's reversed. And so Hispanic, Asian Pacific Islander, and Black non-Hispanic children all had a significantly higher autism prevalence than white children. This also held up pretty consistently, not just overall, but when we looked, you know, within states too. And so there's really been a big shift. So not only local data are important, but having recent data are really important too, because we can't just depend on things from many years ago and assume it's the same. If you go to the next slide, this, I like this graph, but you know, some people haven't, but you tell me if this is too confusing. But here, these are like those race and ethnicity differences over time. So the orange dots are the white non-Hispanic prevalence of autism. And then the purple are Black children and the blue are Hispanic. And this just shows what was presented in each report. And so you can see in the early years, higher in white children, orange dots are higher. Then for a number of years, it's getting closer, kind of evened out. And then in this most recent year, like flipped the other way. So you can see that there's been this big shift over time. And it's not just happening in a couple places, or it's not just when you average everything out that, you know, it seems consistent now. If you go to the next slide, we also use the ADAM data to track whether we're identifying more children early, you know, than we were in the past. And the way that we do that is we look at like up through a certain age, how many children were identified, compare, you know, with children that were, you know, 4 years old in 2020, which are shown in orange, versus 8 years old in 2020, which are shown in blue. And you can see that the 4-year-old children are outpacing the 8-year-olds. So that means that like overall, more children more recently are getting identified with autism at earlier ages than in the past. But if you go to the next slide, again, this is the you know, that was the overall, but again, like each community might have a slightly different story about what's happening. So you might wonder like, well, what's going on? Like Arizona and Utah really don't have that big of a change. And then you have a site like California that was already identifying a lot of children really early, and now it's even more. And so again, you know, if you want to understand what's happening in your community, you really do need data from your community to be able to see like exactly what the situation is. If you go to the next slide, this was one of the new things that we were really excited to do this year, which was wondering, like, did the pandemic and like the shutdowns and lockdowns like affect whether children were getting, you know, the evaluations, and were they getting through, were, you know, families getting what they needed when everyone had to stay home? And so we compared again what happened, you know, up through 2020 to what happened 4 years ago. So if we're trying a build slide here, which is like dangerous, I feel like, when we're saying, so go to the next slide, should put the, okay. So the blue means more identification than in the past for each month of age. So, you know, as children are, you know, up through age 1, 2, 3, and 4. And then the graph stops in February of 2020. So now if we go to the next slide, that's the net. So like once the March of 2020 happened, all of that progress over those 4 years, that increase in identification was completely wiped out. And it wasn't clear that it returned to pre-pandemic levels through the end of 2020. And so we're continuing to, we'll have, we're anticipating another data release in next spring. And so we're eager to see like whether things have changed. So if you go to the next slide, just wanted to mention, the system's pretty flexible. There are lots of different ways, like Adam is very like resource intensive in terms of reviewing records, but we also piloted and demonstrated, and Dr. Hollandy can speak to it because Minnesota was participating in it. We thought, what if we just do this as like a massive record linkage and get all the data in a whole state on all the children that have like either a code or a special education classification for very low cost. We're not getting the depth of data, but we're at least getting baseline numbers. How does it compare? That was what this paper compared. And it was, I think it like bang for the buck, it was pretty good. Like it did get us data in a lot of communities that didn't have data before. And the next slide, another thing that I think is really interesting, and we just published a new paper on this, is what tests and tools are being used in everyday practice to show, like to help professionals identify and determine whether children have autism. Again, like no surprise, it varies wildly by community. And like the gold standard diagnostic tools are in gold, which was a good move by Ashley Robinson Williams, the lead author. But you can see like just how often they're used and how much is how are these decisions being made? Do they involve these tools? It really is, the communities. New Jersey identifies a lot of children with autism. They just don't seem to invoke diagnostic tools as often as other communities do. And so it's interesting, and it could give you context in understanding why things are happening the way they are in your community. And this, so I have a couple quick examples, but I think I think like hearing from people that are actually like making these changes happen, like Dr. Hollandy, are probably going to be the best for you to hear. But just to give you like a broad sense of some of the things that people have done, these data have been used like for helping make a policy case for different services or launch different initiatives. Recently, I have like a little list here. So the San Diego County supervisors, they've initiated new workforce recruitment efforts for the neurodiverse community. And they cited the ADAM data as like a justification for like a need to do that. The Arkansas ADAM group, they've used their data to demonstrate to state legislators that that the rule for getting a diagnosis, they said that there was a 3-clinician diagnosis rule was a barrier to many children obtaining a diagnosis and consequently services for autism. For a child to receive autism services under the Medicaid waiver, Arkansas code formerly required autism spectrum disorder to be diagnosed by a team of 3 professionals to include a licensed physician, licensed psychologist, and a licensed speech language pathologist. Their new bill enacted in April of 2021 changed the requirement for diagnosis from all 3 to any 2 of the 3 qualified professionals, and they used the ADAM data to help show that the children weren't getting identified as quickly. The data have also been used in Tennessee with their governor's council. They actually, I think they use their statewide data to help show like the disparities that are present in some of the communities in Tennessee, and they cited CDC data to do that. And Utah, in early 2021, the Division of Services for People with Disabilities used their statewide estimates to help estimate the number of people with autism and intellectual disability to estimate the need for COVID vaccines during their initial rollout. And so that was during that time, that felt really good to see the data being used for something that was so important about making sure that that population is considered and prioritized. So I think I can stop there. Happy to talk more about questions, or again, if you want, the full version of any of this, feel free to email me or the Adam inbox. But thank you for your time.
Thank you so much, Matt. We are going to take questions at the end. Folks are asking for your contact information. I have put the Adam website into the chat for folks. Next, thank you for all your for giving us this, I would say, like, wider lens of like what's going on with the data. Next, we're going to zoom in to Minnesota. And we're going to hear from my colleague, Jennifer Hall-Landy, a researcher and psychologist at the Institute of Community Integration and the Masonic Institute of Developing Brain at the University of Minnesota. Dr. Hall-Landy focuses on early signs of developmental delays and early identification of developmental disabilities. She leads multiple disability-focused projects, including the Minnesota ADAM Network, as you already heard, and is the CDC's actor-early ambassador to Minnesota, which is how we know each other. Jen's going to share about how ADAM Network autism data is used in Minnesota and the benefits to her state. Thank you for being here, Jen.
Yes, good morning, or actually good afternoon, everyone. And Yetta, thank you for that nice introduction. I feel so fortunate to be here with all of you today and with my colleague Yetta. We work on the Actorly project together, and it's been great working together, and you are lucky to have her. She does wonderful work. So thank you so much. As Yetta said, I am here from the great northern state of Minnesota, and I'm going to do just a quick snapshot of what our ADAM looks like in our state. We have been an ADAM site since the year 2015, so wow, almost a decade. It's been a while, but we've enjoyed every minute of it. And as Matt was saying, it really gives us a lot of valuable data from local communities that is used for decision making and advocacy, and it really gives us a seat at the table to translate data from these communities into meaningful policy change practice. And I'm going to share a little bit about that. It'll just be a snapshot today, just a little taste, because we have a lot of wonderful speakers, but I'm happy to share. So just a quick snapshot. Matt shared the numbers from the broader ADAM network. Within Minnesota, our numbers look very similar. We're in select communities. We're in our two most populated communities in Minnesota. And what we were seeing for our overall numbers in 8-year-olds was 1 in 34. So about 3% of the 8-year-olds that we looked at within our data. So very similar to the national numbers there, to the broader ADAM network numbers. Next slide. Thank you. So as Matt shared, this data is used really to make changes in states. It's local data. It tells us what is happening in communities. We don't always know the why, but it tells us what it looks like. We count. And it has been very, very valuable in our state in a variety of ways that I'm going to share. One, we partner very closely. I'm going to work backwards for my bulleted list. I sit on the Autism Interagency Committee. That is a committee of state agencies. So we have a Department of Human Services, Department of Health, our Department of Education, myself from the university, our Autism Society, and we talk about policy and trends, and we use ADAM data to really understand what does it look like in our communities? When are we identifying? We have had a seat at the table for, to help inform many different policy changes in our state. One, our early intensive developmental behavioral intervention, which is really the EPSDT benefit within Minnesota. The leaders within that group use ADAM data to help calculate future needs and used it to advocate at the legislature for increased funding. They also use some of the trends that we were seeing within our Minnesota ADAM data to help advocate for additional pay for our direct support professionals, as well as specialized additional benefits for direct support professionals from culturally and linguistically diverse communities, because we look at that in ADAM. We look across race and ethnicity and see what do those numbers look like within those groups, as well as how are we serving, when are we getting to those children. Some additional pieces that I didn't include on here. Recently, one of our large clinical statewide networks is expanding. And when they sent that out, opening several more clinics, they cited ADAM data in their first line. So we love knowing that our data is being used to help increase access to services and supports. Another nice thing that we saw come out, our Department of Human Services offered a large grant to community organizations to be parent connectors. I'm going to talk a little bit about that, and liaisons for families. And again, the first sentence was, here are our MIN-ADAM data. There is a need. We want these connectors out talking and sharing with communities, helping them understand what do numbers look like locally, and how can we meet with services and supports. Next slide. So really just a wealth of benefits. I talked earlier about the interagency, the Minnesota interagency, where ADAM data is used. We developed many resources, one of which is the Minnesota Autism Resource Portal. The data is featured on there. It's additionally a one-stop shop for children, families, professionals, really help. It's updated every day. I don't do it, our Department of Human Services, but families go, they get real-time information. The ADAM data is featured there prominently. And because we are such a meaningful partner in the state, we're allowed to be part of this planning, talking, really helping increase access to services and supports. Next slide. And this is a pathways document we developed as well, in collaboration with our partners to really help give families, and that's online too, a way to navigate the system. I don't think Minnesota's alone, that it's hard. It's challenging. It's complex. Systems are complex. We work in them and we find them complex. How can we demystify and really help with this navigation? And again, ADAM data is used to help us understand better what the needs are. Next slide. One of our biggest partnerships that we have in our state, and it was mentioned by both Dr. Maynor and Yetta, we do a lot of partnering with our Minnesota Act Early, another CDC program. It's wonderful. How do we get to kids earlier? How do we know the signs and get them in for identification or diagnosis as early as possible? So one companion project that we have in our state, next slide, please. We partner with our Act Early project in ADAM, next slide. And we do a lot of this connection within local communities. As Matt said, we know what our numbers look like. In Minnesota, we look across it based on census numbers, racial and ethnic groups, but in Minnesota, we do something additional. We look at our local communities, what autism rates look like in our East African Somali population and our Hmong population. That's something the community wanted. So we continue to provide that. And so what we do, we have a group of parent connectors on our Act Early project going out in the community where families are, sharing ADAM data and also sharing Act Early. They're a beautiful marriage together, great partnership, and talk about what is the prevalence of autism in our community, how do we know the signs early, as well as other developmental delays, and how do we connect families and children to services, those valuable early intervention services, as soon as possible. And so again, we go where families are. So it's really taking the data and then moving it to a community need and being out there. And then in turn, we hear back from communities what their concerns are and what their needs are. So a bi-directional and just beautifully paired together. And next slide, please. So thank you. I only wanted to take a little bit of your time. That's just a little bite, a little glimpse into our state and our data. But again, I can't say enough how beneficial the ADAM project and data has been to our state. And we are really seeing it translate into meaningful differences in the lives of children and families. So thank you.
Thank you so much, Jen. So next we'll hear from April Grady about the DC Department of Healthcare Finance, background about Medicaid and what claims are, and autism-specific data from DC. So April Grady directs the agency's analytics and research team at Department of Healthcare Finance, which transforms data into meaningful information to support the district's Medicaid and locally funded healthcare programs. So prior to joining Department of Healthcare Finance, April was a director at Manat Health, where she led the firm's Medicaid analytic work. And she was also a policy director at the Medicaid and CHIP Payment and Access Commission, where she helped develop and manage MedPAC's policy and research agenda, along with its data analyses and publications on issues ranging from program spending and financing to the needs of complex populations. So we'll turn it over to April to present on the DC data.
Thank you for the introduction, Leandra. Next slide, please. Okay, so I'm going to give a little bit of information and background on the programs that the Department of Healthcare Finance is responsible for here in the district. Medicaid is our largest program, and it covers nearly half of all residents and about 70% of children in the district. So while I'm giving you a slice of the population here, we do cover many of the children here in DC. Many folks are probably aware that we have near universal healthcare coverage in the district, and we have the second lowest uninsured rate in the nation. Our population right now, we cover more than 300,000 people. Again, most of those are in our Medicaid program, which receives federal funding. But we also do have 2 local coverage programs for immigrant populations that do not qualify for Medicaid. So those are our DC Healthcare Alliance and our Immigrant Children's Program. So when you put those all together, we got about 70% of district children. We also reach a lot of the children who are eligible for our program. So we estimate that 96% of eligible DC children are actually enrolled in the Medicaid. So we have very good reach into the low-income folks who do qualify for our services. And last, I just want to point out that most of our children who have Medicaid coverage are in managed care plans, so about 90% of them. So that means that we contract out with these plans to administer and deliver benefits to those children. We do have about 10% of our children who are in the fee-for-service program, which means that we, the Department of Healthcare Finance, manage their benefits and pay their services more directly. And that's pretty much limited to children with disabilities, those who are in foster care receiving adoption assistance, and those who may have justice involvement, for example, with our Division of Youth Rehabilitation Services. And we enroll a wide range of provider types to serve our beneficiaries. Very commonly, we see FQHCs providing care, but we have additional facility-based providers like Children's National, Howard, Georgetown, physician and other practice groups. So we do reach a wide swath of the provider community with our population as well. Next slide, please. And then an important aspect of the Medicaid program that was mentioned earlier is the early and periodic screening, diagnostic, and treatment. It's always a mouthful, EPSDT benefit. And that's really important in the Medicaid program because by statute, we are mandated to cover any medically necessary benefit for an individual under age 21, regardless of whether our program normally covers that benefit. So when we think of autism spectrum disorder, applied behavioral health analysis, other types of treatments, even if those aren't named as a covered benefit, normally those are things that we will provide as part of our EPSDT benefit for anyone that has a medical need for that. Next slide, please. Okay, so this is starting to get into the heart of today's discussion, which is how many kids. So the data that we, DHCF, Department of Healthcare Finance, have reflects children who are diagnosed with autism spectrum disorder during a visit with a healthcare provider. So during Matt's presentation earlier, he spoke to that sort of diagnosis and healthcare claims piece of it. I think it was the green bar, if I'm remembering your slides correctly. So we're sort of missing the blue bar and the purple bar, and we have some folks from our DC education team going to speak next to the education piece of it. But the claims and the diagnoses with the healthcare providers do account for a lot of what we would see in terms of identifying the population with ASD. So I just want to be clear that we're a slice of the pie, a big one, but still just a slice. So the information I'm showing you here today is based on that information. I do want to point out that we did look at both children with ASD and also intellectual disability diagnoses. I saw that there was a question about this in the Q&A, so I can say a little bit more about that, but we do have both populations encompassed in what we're showing here. Next slide, please. Okay, and this is just a summary of some additional data slides that follow this. I'm not going to go through every slide because I just have a few minutes to speak, but you'll have this information if you don't already for reference offline. But the bottom lines in terms of the population size that we see for our DHCF covered children, approximately 2% of our 2022 population under age 2 had some record of an ASD and or intellectual disability diagnosis in the past year. So that's about 2,000 DHCF enrolled children. Most of that number is children with an ASD diagnosis. We do sometimes see a dual diagnosis, so both ASD and ID, but it was more common in our data to see either ASD or ID by itself for the time period that we looked at. And in terms of the percentage and the trends that we've seen over time, consistent with the data for other localities that was discussed earlier, we have seen an increase in the percentage of the population with a diagnosis. So in 2018, when we looked at the data, it was about 1.6%, and in 2022, it was 1.9%. So assume that will sort of continue to trend upward in the future. In terms of the characteristics of our population, we looked at the ASD and ID population and looked to see how they compared to the other children that we cover who don't have a diagnosis. And what we found is that the children with an autism spectrum disorder or intellectual disability diagnosis were more likely to be male, more likely to be African American. And we did look at the distribution within the district. It was pretty even. There were no sort of specific pockets. So it was pretty proportionate in terms of the neighborhoods that folks live in. We also looked at service use and what other kinds of co-occurring conditions that these beneficiaries had. Not surprisingly, some of the most common services that they're using through the Medicaid program are speech, language, communication, and other therapies, in addition to just the regular well child visits and routine medical care that any child enrolled with us would get. We also looked at co-occurring conditions, and again here, not surprisingly, additional neurodevelopmental diagnoses such as speech language delays and disorders and ADHD were commonly seen for this group of folks. So I think I'm going to end it there. The additional slides we have more detail. Happy to answer any questions afterward. Thank you.
Great, thank you, April. So next we'll hear from Chandy Wagner about data from DC schools. So Chandy is the IDEA Part B data manager for the Office of the State Superintendent of Education, which is the state education agency that supports all of DC's public and public charter schools.
Great, thanks so much. I only have one slide for you. So as I'm sure you all are aware, the medical and educational diagnosis for autism can be different. A student may have one or the other or both or neither. And so we just wanted to talk a little bit about what's included in our data. If you ever see data on our website, we have lots of publicly reported information. So we, as the bio mentioned, we oversee the implementation of Part B of the Individuals with Disabilities in Education Act, or IDEA. And that includes the provision of a free and appropriate public education by local education agencies. This is a lot of acronyms. So basically it's schools, all the public schools, or students who are placed into non-public placements by their local education agency, whether that is DCPS or a charter LEA. In school year 22-23, we had 2,241 students who received autism services, and that is 2.3% of our enrolled public school student population. And that can be students who have a primary disability of autism, or it may be part of a multiple disabilities diagnosis, which may include things like speech language disorders, things like that. So overall, we're at about 2.3% of students, of our public school students, receiving those services. In terms of who's included in those data, as we've mentioned, it's students in DC public schools, DC public charter schools, students in a non-public placement. So maybe their schools just doesn't have the full spectrum of services that that student needs, then the public system does pay for them to attend a non-public school. And then parents can also choose to place their student in a private school and receive just speech services through DCPS. So that is also an option, and it's a pretty small group of students. And most of those students, I think, do not have autism. If you have more severe disabilities, you also need more services. Excluded from our data in Part B are students who may be ages 3 or 4 and still receiving their Part C services through Strong Start, which is our early intervention IDEA Part C program. So those students would not be in our system in terms of how that works. They can coordinate care and get services for students, but they don't have an official diagnosis per se, at least within our system. So that those students are not included, even though they may be of school age in DC. They are not receiving Part B services, but they would have to be determined eligible for Part B services in order to continue with those Part C services in age 3 or beyond. And then parents who just enroll their students in private schools and maybe access services on their own. We just don't have information on those students either because they're not in our data systems. So that's just a general overview of what we have here at OSSI, what our data portray. We are always striving to get better and more comprehensive data and share that with the public as appropriate.
Great. Thanks, Jandy. So thank you to all the speakers for walking us through. So we just want to review a few key takeaways from the discussion before we open it up to questions. So based on the data presented, which suggests kind of lower 1 in 58 or 1 in 65 children have an autism classification in DC, we kind of see fewer children in DC identified as having autism than would be expected compared with the national data, where you see that 1 in 36 children with autism. So that suggests we may be underdiagnosing or under-identifying autistic children in DC, but we don't really know the true prevalence. So looking at the health and education data separately helps us learn more about autism in DC. We don't know how well these data capture children with autism, in part because we don't know how much overlap there is in those data sets because they're not linked. So we also know, as was mentioned, these data sets may miss some children, and details vary between the data sets. So we've not yet fully explored some differences based on race or ethnicity, sex or board. So in terms of some possible next steps, we want to share information widely with others. So we've developed this one pager that you see on the right, where we'll share after the webinar, and it's posted on the DCAC website that summarizes what we've been discussing today. Our Children's National Team has also published a paper in 2021 that outlines many of the challenges in caring for children with autism in DC and outlines several recommendations, and that's also available online and could be shared to provide further context and information. And then another idea for a next step would be establishing more of a data tracking system that could link the health and education data similar to what other states have done. That would allow for more accurate understanding of the number of children with autism in DC.
So now we want to open it up to our audience to ask questions and to learn what other ideas you may have for next steps. Please put your questions and comments in the chat, and we've already received some. So I'm going to start with this first question and comment. I think this is for you, Matt. Do experts think that the increased rate reflected on these slides is only the result of increased diagnosis of cases that may have been missed in earlier years, or that incidents are rising? So the individual said, for what it's worth, our children's program in shelters in DC and PG County is seeing a rise in behaviors consistent with ASD, regardless of diagnostic status. We are anecdotally seeing an increase even in the last 20 years. It's felt dramatic, especially in PG County, Maryland.
Starting with the hard questions, but also a really good one. And I guess, like we talk about, like, scientists are often very careful in saying like what we do and don't know and trying to adhere to the evidence. But then, like, when people have to make decisions, you have to sort of take what you know and go with that, because you have to do something, and doing nothing is also something. So with that, the way that I tend to try to think of this is, we do have quite a bit of evidence that changes in awareness and diagnostic practices have contributed to identifying more children, certainly. Now, if the question is, does that fully explain everything, every last bit of it? no, we don't have the ability to measure that, like, absent having a time machine. And that's not like the first thing we would use a time machine for. If if that doesn't explain all of that, that still doesn't mean that we do know what would explain that. So if we say like it explains some but not all, we still don't have good evidence about what that other stuff is either. And certainly people have tried to look for it. Like risk factor epidemiology for autism has looked at tons of things, and usually either it's a small risk or the exposure, the amount of people that are exposed to that thing is low enough that mathematically it couldn't explain an appreciable chunk of that change. And many years ago, I think it was even before I came to CUC, I worked with some colleagues, and we sort of tried to model that out and create a formula to show, like, if this exposure changes this much and the risk is this much, this is how much you could expect autism to change. And it wasn't, a very popular paper in the research community because it sort of, deflates the, enthusiasm for continuing to find like, what is the smoking gun? So I know that there are concerns about increases in behavior problems, especially in the last couple of years. I think during the pandemic, those conversations about, developmental readiness for school, like those conversations are here too. And I think that we're in the same, situation where we don't have evidence to point to something to say what it is. Certainly there are, it's potentially increases in awareness have contributed to that. People being at home, the advent of telemedicine services that might facilitate getting children, but we do not have the evidence to point to say that there is clearly like an increase, but I think it's also the observations about the changes are also, they're valid and they're worth trying to understand.
Thank you for that, Matt. For this question, so this is similar question coming from two different folks. So I'd love to hear your thoughts about the shift in diagnostic rates for different racial and ethnic groups. And then the other question related, the data shows significant change in the diagnosis of Black and Brown children. Is there a reason for that? Easier access to assessments?
Again, and I think with this, I think Jen actually said the key phrase, which is the data show us what is happening, but not necessarily why. And that can be kind of frustrating when you have these data, because, on one hand, I think like the optimistic view of it is that like we're able to have these conversations in the first place now to say this is happening, that we wouldn't be able to say without the data. But we can't, go a step further beyond what we have. And I think that's where, like when you think about what these, these would be considered public health surveillance data, sort of like the routine reporting of the changes that are happening. And so then the next step, if you think about it as like a cycle, is you see these data, you try to understand what it means, you take some action. It could be further investigation to like really dig into a certain issue. It could be the implementation of a policy or change in something to try to address what you're seeing. And then, when the next round of data comes, you can use that to evaluate the effectiveness of the action that you took. In this case, it's hard to say what the changes are or what the actions that we took are or what we would be evaluating, but we certainly do see those shifts. I will say they weren't, it wasn't just those changes weren't just seen in certain communities. And actually one of our ADAM colleagues from New Jersey actually published an analysis of special education data that also showed this shift in race and ethnic differences in prevalence too, just using like the publicly available education data. And so, in terms of, so like one question for us is like, is it just an artifact of like the way we do things? And it doesn't seem like if it was, it would be specific to us because we do see it in these other data too. And so I think I at the risk of rambling, like I'll conclude there, but it's tough when you can't point to like a specific thing.
Yeah, I appreciate that. And I was gonna say, Jen, I saw you nodding your head. Did you want to add anything to that? Thank you, Matt.
No, I think Dr. Maynor said it well, and this may not be a satisfying answer. We can't always answer why, but what ADAM data does is give us a seat at the table. You know, whenever I go to the legislature, I'm listening, someone talks about autism, the first, what comes out of their mouth first? The rates. And so it is a place to start, and it tells us what we're seeing in communities. And it may lead to additional research questions or the why. But right now it gives us a lot of valuable data in terms of that. And I guess too, I know I get a lot of, it's a great question in terms of when people say why and the increasing numbers. I get it too. And while we can't necessarily, you know, understand everything that's going on in a community, if we look at across the United States, some of the changes that have led policy changes. For example, when the AAP implemented autism screening at 18 and 24 months, of course, then we're going to identify more children. So our numbers, we see that in our numbers. You know, in the early 90s, when autism was added as a special education category, you know, ADAM data looks at those numbers, so that it's a reflection of that. So definitely awareness is a piece, and our diagnostic criteria. Certainly through the years, as we move through the different DSMs, we've broadened it to a spectrum, so we're picking up more kids. So I know many questions remain, but if we look at even some key policy changes, we then see the downstream effects in our surveillance data. So it is, those are meaningful factors.
Thank you for that, Jen. For the ADAM data, while ADIR and ADARS are often highlighted as gold standards for autism diagnosis, there are barriers to diagnosis for a lot of populations. Can speakers comment on potential discrepancies between children who can assess ADI or ADOS and those who would be able to be diagnosed or classified with autism through other approaches?
I mean, I'll say so. So one clarification. So I kind of agree with the comment, but I think like to the you know, in terms of the ADAM data, we are just looking at whether those tests were administered and not like what they said, or whether like it would be too complicated to do this at a large scale to say, did the clinician ever overrule it? Or what if the test said no autism, but then the clinician said autism too? Like that would just be too complicated given just the sheer number of tests, the way in which they're used in practice. You know, are they really doing the full thing? Are they doing like, you know, so we don't have the ability to look at like we can say whether a test was used in a child's history, but not necessarily what the outcome of that was, or like whether the clinician agreed or disagreed. But in the paper, there are, I think, some descriptive data on like who did and didn't get a test in being identified. And that might be telling about like sort of that path that they took, the way they entered the system, what their experience was like.
So here's another question, and I'm going to say this really quickly. I think the turning point for me personally in like understanding this data was that the ADAM sites are sites across the US. They're communities, right? It's not prevalence across the whole United States. And that was totally a turning point for me. And I think a lot of people in the larger community were surprised to hear that. So I think that's one important thing to note. With that said, one of the questions that came in is, do states with ADAM sites have more accurate ASD stats and data than states that don't? I mean, there's a reason why we're doing this here today for DC. I'm just going to say that, and I'm going to let you all answer.
I mean, I think the word, like, again, like using language as a scientist, or, you know, I guess now I'm like more of a former scientist, but like, I think using a word like accurate is really challenging and loaded, because it's like, compared to what? I think that you could say it's more detailed, more comprehensive. You can be more certain about like having like some ground truth according to the standards that you're collecting the data. You can know, I think with ADAM especially, that like by combining multiple sources across the community, that you're not double counting kids, you're not missing kids that are only identified in one place or not the other. It was wonderful to see the different agencies represented here today, because I think these are a lot of the big pieces, and certainly they can do a lot of great things on their own. But I think the real like if you want to know what's happening in your community, you need to sort of work together and get all the data in your community linked up. And then I think you'll really have the best picture you can. I think the idea of accurate comes back down to like, well, what's the standard? I think it'll be a more accurate picture of what's happening, certainly.
Yes, 100%. Thank you for that, Matt. And another quick follow-up question, and I have there's a great question I want to end with, so I just want to like address this. So one of the questions was, does Adams sites only collect data for the states where they are located? That is correct, and not even the state, you all. It is for the community. So Jen, can you really quickly state like what area in Minnesota as an example for folks?
Yeah, absolutely. And that's a great point. So when Matt brought up that map, and if you saw Minnesota on there, you saw the cluster around our densely populated urban area. So it's 3 of our most populated counties. If anyone knows Minnesota, it's Hennepin, Ramsey, Anoka. So it's not all of Minnesota. So you bring up a good point. We can't even say our prevalence numbers are representative of the state as a whole, because we know that if we went out to greater Minnesota, less access to resource, we likely would see lower prevalence. And so we really, we add a lot of caveats in order, just like what Matt was saying, you have to be careful with your language. And so what we really say are, these are the prevalence numbers in Minnesota communities where we collected the data.
Thank you for that. A couple of comments. One reason that educational autism identification in DC may be lower than expected is that some children with autism are likely classified under more general category of developmental delay. Thank you for that comment. I believe it was in your presentation, Matt, there was a comment that came in about the mention of diagnostic substitution. So there are many individuals diagnosed with ASD, but less diagnosed with intellectual disability. Although you can be diagnosed with both these days, some children are only diagnosed with ASD when they actually do have ID as well. So want to flag that. This is the final question in the last moment, because I want to keep everybody on time. Sorry, we don't have time to like go into that deeper. Are there any asks from the presenters for the local community, so in DC, to move the needle and increase or improve data collection, any advocacy needed? I'm just going to start and say, this right here is the beginning. This is the beginning. We have been, well, not the very beginning. Let me just be fair. It took a lot to get us to this point. But we want folks to know that we do not have this prevalence data. And it's important, and I hope that today has helped to make the case for reasons why. Leandra, did you want to add to that?
No, thanks, Yetta. I appreciate that, and agree. This is the beginning, hopefully, of some next steps. As we said, I do, I think that linking the data sets is a big one, and I just encourage folks. We're going to share the recording and the slide and the handout. And so would encourage folks to share that widely. And if folks are interested in getting more involved in the DC Autism Collaborative, it is, would just encourage you to reach out, because we want to work with the community and all our partners in the health and education sectors to figure out what those next steps are.
And if you can just pull up the slides, and literally our 0 minutes left to finally wrap up, because there are a couple of things I want to share with folks. So of course, we want to thank you all for joining. We have one more ask before we wrap. I serve as one of the 3 co-leads of the DC Autism Collaborative's Community Resources and Support Subgroup. We're conducting a survey of the DC disability community, all ages, about how they use and access the DC Department of Parks and Recreation programs and facilities. Please share this widely. We want to hear from you and complete the survey if you are a person with a disability, or parent, caregiver, or supporter. This is very important information, because we want to make sure that everyone is accessing DPR services. So thank you to all our speakers. Thank you to all of you who have joined. We will be following up. So thankful. Take care, and let's get this done.